Well, good afternoon, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup. My name's Jason Beldman. I'm the Director of Emergency Preparedness for CAF. Today is April 16th, 2021. It's 1 o'clock in the afternoon. And as always, you can find COVID-specific resources at caf.org/resources/coronavirus. We also have a separate disaster preparedness website. That's cafdisasterprep.com. And you can always download any of the tips, tools, and templates that we have on that website as well. I want to apologize. There are two AFLs that came out about an hour ago or 2 hours ago. If you're watching your inbox, you probably saw the KHAN notices. I'll cover, because I don't think the changes were that big, that I may be able to just cover what they are here on the webinar, but I don't have a link to that specific AFL on the slides built yet. I didn't have a chance to add it in there. So with that, let's get started. I think we have a short program today, not a bunch of changes, but there are some significant changes to the PPE guidance from the CDC, and we're going to cover that in depth as well. All right, let's hop to our first kind of standard greeting for the program. The speaker's opinions expressed are their own on this webinar. They may not reflect CAF's official position. These webinars are brought to you as part of a grant-funded program through the Hospital Preparedness Program, CDPH, and LA County Department of Public Health finances. I have no personal financial conflicts. The intent of the webinars is to give you a situational report for the week's activities, regulatory changes, things like that, with some forecasting and best practices where we can identify those. All right, let's hop right into the AFLs. And of course, I said no AFL, and certainly an AFL did come up, and I'll address that in a second. But in terms of the AFL 21-08.2, we talked about this briefly last week, and Dr. Epson was able to clarify this on the call on Wednesday and Thursday. Hopefully, I think we've got this part clear in terms of what to do after travel and things like that. But definitely, if you have questions about that, just send me a note, and I can ask Dr. Epson if it's like a one-off question. I know we had one on the call the other day about folks visiting specific areas of the planet, meaning some areas may be more at risk than others. At the current time after travel, there is no recommendation to quarantine for fully vaccinated people, regardless of wherever they do travel. So I wanted to make that clear, because we have folks in our employees that are that leave the country frequently. So that should not be a barrier for you guys. In terms of the AFL 2022.6, I'll just let you know that they released AFL 2022.7. That AFL really expanded upon the visitation for pediatric residents. So for those of you with pediatric subacute facilities, there were like 8 bullet points that were added into that AFL that talked about pediatric visits specifically. For the other guidance that's tied within that AFL, where it ties to the CDC guidance, we wanted to let you know that that CDC guidance changed on March 29th, and I apologize, it did not add it last week. I had missed that that it changed. But for residents that leave the building for less than 24 hours, it is not recommended that they quarantine upon return. And that's obviously, if they're already a part of a yellow or a red cohort and they leave and they come back, they're going to go back into the same cohort. But for non-vaccinated, vaccinated folks, it doesn't matter. Anybody leaving for less than 24 hours, the CDC does not recommend quarantine. Residents should follow infection prevention and control guidance as it relates to masks or face masks for source control. Monitor or maintaining social distance or physical distancing while they're out of the building. They perform frequent hand hygiene. The folks that accompanied the residents should also follow those same infection prevention and control guidance requirements. There is some flexibility in there to quarantine if the infection prevention and control adherence is unlikely or the exposure is unknown. But really, I think the CDC and everybody wants to kind of minimize the need to quarantine those folks in the building. And so I just wanted to cover that. The link to the CDC guidance is linked on both of those sections, so you can print it off and download it and attach it to your existing plans. And Patty, did you, I see Patty's on here as well, and I apologize, didn't introduce Patty at the beginning. Patty, did you see anything briefly in that 2022.7 that had changed besides the pediatric stuff, or was that?
No, it was, hi Jason, sorry. It was, I had a little technical problems jumping on again, but I just did the red line version comparing the prior to the current. Melissa worked on that with me. We only thing is they've added a bunch of pediatric bullets, and then now it's signed by Cassie versus Heidi. Those were the only differences. It has a lot more layers for the pediatric and a lot more accessibility for the visitation for pediatrics and who can visit, such as teachers, instructors, all kinds of different types of allowances for pediatric. I will send that today on the forum. I'm just typing up currently the summary of it all to put out on the forum.
Perfect. Awesome. Thank you very much.
You're welcome.
Yeah, and there was another AFL that was released at the same time that was geared more towards hospitals that talked about providing vaccinations without needing physician orders for the vaccine shot. Now, within that AFL, it clearly kind of identifies hospitals throughout the AFL, but there was one portion of the AFL that said hospitals or other healthcare facilities. And so I think we'll need to kind of flesh that out if that applies to not just hospitals, but other types of healthcare facilities, clinics and SNFs and things like that. It wasn't really clear. It did look like it was almost squarely aimed at the hospitals, but because they threw in that language of other healthcare facilities, I think Patty and I will have to flesh out whether that was meant for SNFs and clinics as well. So we'll address that on the forum if it does apply to SNFs. I think now for the vaccine, some, maybe not all counties, but some counties have standing orders listed on their public health websites that you can use for vaccine. In other counties, they may not have standing orders, and you may still be doing that internally if necessary. So we'll get clarification, and we'll put that on the forum once we get it. All right, I want to talk about the changes in PPE guidance. So the CDC has categories for PPE usage, and they break these categories down into conventional, contingency, and crisis capacity. And each one of these is kind of a flow format for each type of PPE. Now, the changes I want to address have to do with uses of respirators or N95s. This guidance changed on 4/9, and they moved some of the what was considered a conventional strategy into contingency strategies, and something that was in contingency is now in crisis strategy. So, and what does that really mean? It means that if we get audited on the use of our personal protective equipment, if we're using it in a non-conventional sense, meaning we're operationalized contingency strategies or crisis strategies, we're going to have to justify why we're using those strategies. Is it a resource issue? Is it an issue, with non-fit tested equipment? What are the reasons why we're using different capacity strategies? I'll just say in the conventional strategy, they added the use of N95s with exhalation valves as acceptable use for source control. So prior to this change, it was not N95s with exhalation valves were not to be used as source control or as respirators. They did add on language on extended use of N95s as respirators as source control. And essentially what they've said is extended use of an N95 respirator under conventional strategies means it's one use until they take it off. And so that means if you wear a respirator, or I'm sorry, this is the conventional or the contingency strategy. If you use a respirator and you take it off for a meal break, that respirator needs to be discarded. That's under the contingency strategies, and that was not a part of the strategy before. The strategy before was you could take it off, don it, and doff it up to 5 times before needing to discard it. That was under the contingency strategy. That has now moved to the crisis strategy. So you cannot, so you can only use each disposable N95 respirator 5 uses. That's under a crisis strategy. And most of us, I'd be surprised if you were operating under those crisis capacity strategies now. If you are, you got to be crystal clear in your documentation of why you're using crisis capacity for these types of devices, specifically the N95s. As we look at the strategies for conventional contingency and crisis for other types of PPE, it does not seem that we're in a kind of a source crisis yet on some of those other things right now. But definitely this has changed, and this is going to make us burn through respirators quite a bit faster than we were if you're utilizing that 5 donning and doffing procedure, because now you're going to have to step it down to really 1 use for contingency capacity. They also said that, and this is kind of, it goes without saying, but you should prioritize respirators if you're short for healthcare professionals or personnel who are using them as PPE over those who are just using them for source control. And they removed the allowance under crisis capacity to use non-NIOSH approved N95 respirators. So any non-NIOSH approved respirator is no longer allowed under the crisis capacity. So things like the KN95 masks and things like that cannot be used for crisis capacity strategies for the remainder of the response. I suppose if things get really bad again, it may go back, but I don't anticipate that. And decon is no longer allowed of N95 respirators. And so it's not anticipated that we're going to be able to put those back in service. But if you have a number of decon masks that you've been holding on to, maybe hold them for a little bit longer, but it just does not look like we're going to be able to put those back in service if you've been doing that. So those are the changes. Each change is linked. So the overarching change in guidance is linked on that very first bullet. The conventional changes are linked under the second bullet. The contingency changes are linked under the third bullet, and the changes to crisis capacity are linked to the fourth bullet. And the non-NIOSH link is a link to where you can find out if your individual respirators are NIOSH approved. That's a listing of all the manufacturers that have NIOSH approved N95 respirators, and you should be able to search or make a model on that link there. All right, so I want to hop to a vaccine update and give you some good news. And I'm optimistically cautious about these numbers. I'm not certain they're completely accurate, but we will take the success where CDPH has identified it. And the rates that I'm going to quote, I received from the Department of Public Health Public Affairs Office. So this is information that they've released to the public. How accurate it is might be up in the air, but in terms of SNFs, the staff in skilled nursing facilities as a state, we've reached 92% of all staff have received the first dose of the vaccine, and 86% of the staff have received a second dose of the vaccine. So that means 86% of our staff are fully vaccinated. That's a great number. For residents, 98% of the residents have received first dose, and 89% of the residents have received second dose. So those are both extraordinarily high numbers, much higher than we had originally anticipated. And I think even in our best case scenarios, we didn't think they would be that high. And that's why I'm a little cautious about the number. And we've done an intermittent job of data collection at this point. So we could be off by a fairly significant percentage there, but I think as an industry or profession, nationally, we all have a goal of having 80% or more vaccinated residents and staff. Even if we have big errors in this data collection, I think we're pretty darn close to that number, if not exceeding it. So that's great news. You guys all get a big thank you, pat on the back, give your staffs a big pat on the back and thank you, all that good stuff. That's all great news. I will say that if you follow the news and things like that, there have been some documented breakthrough infections identified specifically in skilled nursing facilities after full vaccination. These have been anecdotal cases. They've not been studied in depth, but they do look like they are breakthrough cases. In one case, I had heard of 5 breakthrough infections in an individual facility and fully vaccinated residents. The good news is the facilities that I've heard those conditions from, no severe symptoms have been reported and no hospitalizations have been needed. So those are fantastic news. So even if we get breakthrough infections, if we keep folks out of the hospital and keep them from getting sick, we're in a really good spot. I want to bring to your attention, I'm sure you guys have heard this. We've messaged this out, and I know CDPH has messaged this out as well, but FDA and CDC recommends pausing vaccine distribution of the Johnson & Johnson vaccine. I'll just say that it's a really small percentage, 6 cases out of 6.8 million doses have been identified. Now, what I've heard is that may be slightly underreported due to the delay in symptom onset, because it appears as if the symptoms in these cases don't appear until 6 to 14 days after the initial dose is received, and sometimes even later than that. So there may be more cases undiscovered because this is such a new vaccine, but it is a really, really small percentage. So if you have staff or you have residents that have been vaccinated with this vaccine already, you might want to just let them know this is yes, there is some risk, but the risk to you is extraordinarily low. We pause out of an abundance of caution to make sure that there's not existing pre-existing conditions that we can identify that would we would stop folks from taking that type of vaccine. So as that gets explored, we'll learn more. I know that there was a big push nationally to use the J&J vaccine in our spectrum of care, simply because of the ease of application being one shot and storage issue being refrigerated rather than ultra cold storage. So we think that there may be some long-term care pharmacies that may be impacted. We just don't know what that impact will be as of yet. If you may have already received communication from your long-term care pharmacy that may have indicated they've had an impact and they were planning to provide you with the Johnson & Johnson vaccine. If that's the case, I don't want you to just give up trying to get vaccinations. If your long-term care pharmacy was planning to use J&J and they have no other option for you, I would reach out to your local health department and ask them if they could identify other sources that you could utilize. There are a lot of other kind of modalities to be able to do this now, and I think the health departments have stood up the ability to be able to support those smaller needs. But you have to be vocal about what they are, when you'll need them, and what vaccine you'll need and all that kind of stuff. So, and in terms of the vaccine booster shot, I know that folks have asked, a real question is, we've been told, or we think that the protection from the vaccine shots will last a finite period of time. When that period of time, when the protection ends, I think is unknown. But the CEO from Pfizer, as well as folks from the CDC, have all indicated that it's likely a booster shot will be needed within 12 months. And they're exploring those possibilities now. The president made an announcement, the president of the United States made an announcement, or his team made an announcement about the likelihood of needing a booster shot within 9 to 12 months. I've linked the article on the possible need to get a booster shot. I think it's probably likely that we're going to have to do that, especially if the CEO for Pfizer comes out and says that. So I put a link to that article there. It's very interesting if you're interested in reading it for long-term protection. All right, I want to hop some big changes for Los Angeles County, and I realize not everybody here is in Los Angeles County, but it represents such a large subset of our facilities. I wanted to bring this to your attention and also let you know that there is a webinar where they're going to discuss all this stuff in 40 minutes from now. So we're going to get off the this call, and I'm going to hop straight to that call so that I can learn the stuff that you guys are going to learn as well. But they have made the changes on their website, and I've linked those changes up here. They did not remove the requirement to test a random sampling of residents. So you still have a requirement to test 10% of your residents. They did add a section that they want that 10% to be non-fully vaccinated residents. Now, if you saw the number I showed earlier, where we've got 89% of our residents fully vaccinated, it may be difficult for you to find 10% that are non-fully vaccinated. And I think if that's the case, I would, start by doing a risk assessment of the residents that have been vaccinated, and prioritize those that are most likely to have severe outcomes if they do become infected with COVID. So I realize 10% is going to be above, and maybe you're going to be testing the same 10% all the time. I don't know. If you're going to join that webinar, I highly recommend you ask that question of Dr. Raj or Dr. Nee. I think they'll both be on the call, but definitely I'm not sure what you're supposed to do if your whole building's been vaccinated. But if it was me and they say you have to do 10%, I'd do a risk assessment of the folks that have not been vaccinated, or the folks that have been vaccinated, to try to identify those that have the most risk, whether they're having frequent visitors, whether they're leaving the building frequently, things like that. Those are kind of the folks that I would take a look at if I'm testing non-vaccinated or vaccinated residents. In terms of the inter-facility transfer rules, whether you're moving someone from skilled nursing care to another level of care, they have inter-facility transfer rules, and those are written out, as well as they have a very specific guidance on visitation, and it's very, very nuanced. It is really in depth. So in that first link there, if you click on that link, it has bullet points for each kind of operational question: testing, cohorting, visitation, things like that. So if you click on the visitation link, it'll scroll you down in the middle of the page, and it's got a very lengthy set of guidance documents on visitation, breaking it down by vaccination status, by where the person is cohorted in the building, what their status is. Frankly, it's really too much for me to go into here when it's going to be repeated in the webinar in half an hour. So if you want to learn about that, that's what they're going to talk about that on the webinar. And I highly suggest, if you're in the County of Los Angeles, that you should pay attention to that webinar. All right, I think we've got to the end of our time here. I wanted to try to wrap this up within a half an hour, but let's see how many questions we have in the question and answer box, and let's fire away. Okay. All right. So we should be changing N95 between each resident in a yellow zone. So that was the first question. And if you are on your normal strategy, the normal strategy for N95 use is disposable, meaning your conventional strategy for N95 use would be, or any respirator use would be, it would be donned prior to the interaction and doffed at the end of the interaction, and discarded at the end. Now, if they're wearing an elastomeric or respirator or a PAPR or something like that, obviously those are not discarded. But if you're in a normal capacity strategy, N95 use is supposed to be disposable. My guess is most of you guys will be in the contingency strategy, meaning a respirator would be given to an employee. That employee would wear it until they need to doff it. When they doff it, they would be assigned a new respirator. And so I'm thinking, in terms of shifts, you start your shift, you wear a respirator if you're working in the yellow zone as extended use, and keep that respirator on until your first break. Take that respirator off. At the end of your break, you get assigned a new respirator, and just follow that same procedure. I think that's probably a good strategy for non-conventional. So we'll go from there. Patty, did you have something you wanted to say? Apologies.
Oh, no, I do, but.
Oh, go ahead.
Oh, I just wanted to make sure when, just breaking news, CDPH just recalled both of those AFLs. They recalled 2022-7 and 2026-7 that they just sent out before this call. They've already recalled it. It must have been a technical glitch error in some language they noticed. So I'm sure they'll be reissued soon, but we'll have to look at those again to see what changed. And just letting everybody know, hot off the press.
Oh, perfect. Yep. Thanks, Patty. Of course, we just, spent all that time explaining it, but I don't, it's usually when they change those things, it's just a procedural error is my guess.
Yeah, usually it's just a minor error, change in language. Yep.
All right, so the next question we have, it says, are you able to comment on the PCORI research grant to improve vaccine uptake? Thank you for the website. I'm gonna look it up. I've not been made aware of the research grant. I think if the numbers hold true, and even if they're pretty darn close, I mean, gosh, we're at a really, really high percentage. And I think when we look at a vaccine uptake or acceptance in the general community, or we look at it in our buildings in relationship to flu vaccines, those numbers are extraordinarily high. I mean, way higher than what we get for a flu vaccine. So, gosh, we're so much higher than where we were. I think, we could still work on getting our individual staff members, vaccinated, and we should, every time we have a vaccine clinic, we should offer it to anybody that's not taken it already. I'm not certain, what there is to do improving vaccine uptake. I think, some of the things we think about could be struggles with language, and have we presented enough information in alternate languages. And I know many different languages are spoken in our buildings. And is that an issue? Are there cultural issues that we're not addressing? Are there sincerely held religious beliefs widely across our staff that would restrict them from getting a vaccine? So I think there will be a percentage, regardless, that will not take the vaccine, whether it's contraindicated medical conditions or sincerely held religious beliefs or things like that. There will always be a percentage. The question is, how high can we get that percent? And at 90%, if we can get there, I'm not certain we can get much higher. But I'll take a look at the research grant and see if there's there's some material in there that I think would be effective in improving our vaccine acceptance rates, because it's incredibly important. We can see what it's done for the surge in our buildings and the ability to keep our residents out of the hospital. It's fantastic. So Has there been any, next question, has there been any specific guidance on visitation for ICF residents? And that's a great question, and I wish I had better news for you, but CDPH has given us indication that ICF facilities should follow AFL 38, 20-38. That's the general visitation guidance, AFL. And for ICF specific information, they should follow the QSO 20-14, which is ICF ID specific for visitation. Now, I will say that QSO from CMS is still a little bit more strict than what CDPH allows. And so we're working with CDPH to try to resolve those more strict guidance requirements. And they didn't, in the CMS QSO, it does not talk about vaccinated versus unvaccinated, and it doesn't address clients that leave the home and come back. Now, for clients that leave the home and come back, I do believe that CDC has guidance for that, and that was linked earlier for the AFL 20-22.6. That same guidance applies to long-term care facilities, even ICF facilities, in terms of quarantine folks on return. Now, we're going to talk to CDPH about asking them to release something specific to ICFs that's consistent with the SNFs that at least offers the same allowances for visits between vaccinated resident or vaccinated clients and vaccinated visitors and things like that. So stay tuned. I wish I had better news for you. I wish I had something, but I don't think this is going to be resolved for the ICF folks within the next week, is my guess. Where Patty's scheduled to meet. Patty, when are you scheduled to meet with the department and discuss this again? Is it next week? I think it's next week. If I lost Patty, I think it's next week, guys. So for that question, we'll definitely have an answer for you, hopefully next Friday's call. We are unfortunately at only 50% for vaccinated employees. Would you recommend continuing N95 use for all staff in all zones, or do you think we can return to surgical masks? For me, and this is my personal opinion, please, this is not CAF's official position, but me, if it was my building and I was an administrator, I would write a policy into my plans that said, for anybody that's not vaccinated for the COVID vaccine, that they need to wear an N95 while they're in the building, period. And I mean, this virus transmits primarily through respiratory droplets and short-range aerosols. It's what's coming out of their mouth. What they're breathing out is what's most likely to get our residents sick. And so if I can protect my residents by making those folks wear a respirator, then that's what I'm going to do. And that's what I would do. For everybody else that's been vaccinated, surgical masks are appropriate. Now, this is just my opinion. It's not, obviously, this is not a regulatory requirement. But that's, when I think about how can I protect my residents, I know that this would be the primary method in which I can do it. All the other things are important. Screening folks, symptom checks, hand hygiene, all that other stuff is important. The most important thing, though, is that respirator. That respirator will prevent somebody from getting somebody else sick, provided they're using it correctly. So that, for me, I think that's where I would start, but it's up to you to make that decision for your own facility. Not everybody can wear an N95 all day. They have to be medically cleared for that. And it's definitely compromises your ability to draw in oxygen. So it's not preferable, but man, as a way to drive folks to getting them to do that, I will say that the Department of Fair Housing and Employment has released a kind of a guidance document as to whether you're allowed to mandate vaccines for your staff. And I think they were pretty open to the ability to require or mandate or write into our employee requirements to have a COVID vaccine. Now, I'm not an attorney, so I can't give you specifics. I read the language on the guidance language on the DFEH website, And it does say that you can mandate a vaccine that's been FDA approved. It does not talk about the EUA process. So it's a little up in the air, but I know a number of facilities have considered doing it and a number of facilities have already done it. So it is in your toolbox. I would reach out to an attorney maybe and ask them, an employment attorney, to ask them if it's possible to do that. Is there any guidance on mandating vaccination for employees? Okay, so I think I just answered that. Next question, can you tell us more about usage of face shields or eye protectors? Do we need to discard after each use? Generally, face shields and eye protection is meant to be repeated. Now, there are some face shields that were designed and sent out or donated during this event that were more of a disposable nature. But by and large, most face shields and eyewear is meant to be used repeatedly. So when you doff it, you would need to clean the face shield or eyewear prior to use again. But that part is not particularly that difficult. It's wiping the equipment down and setting it aside for reuse. In terms of extended use, it may be easier, and it is allowed, that if you're going to have to wear that, let's say you're in a yellow zone and you're moving in and out and in between residents, you're performing extended use on your respirator. I think what they said is you don't need to keep the face shield on when you leave that space, but if you're doing extended use and you have to clean it every time you take it off, it may be easier to just keep it on. And I think that's kind of what the guidance has been. It's not a requirement after you're out of that space, but if it's easier to keep it on rather than doff it and clean it for each use, that is allowed as well. And so I think that's where the confusion lies. It's not necessarily a requirement to wear it all the time, but because it's operationally easier than having to clean it between uses, folks have been using it in that way. All right, next question. Oh, okay, sorry, this is a long one. I gotta go back to the top here. I'm basing the question in relationship to recommended PPE. Oh yes, sorry, okay. Ensure staff are trained on extended use of N95 respirators and face shields, single use only for one shift. Now, I will say I'm not, face shields are not designed as single use items. And I realize they said that in the CDC guidance for, matter of fact, in that CDC guidance that's linked earlier in this PowerPoint, has a link to the use of face shields, and it clearly states that face shields are intended to be reused. As a conventional strategy, not contingency, not crisis, as a conventional strategy. Surgical masks in the clean unit, surgical mask, face shield, gloves, and gown based on the task, like changing linen, giving showers, exactly. In a PUI, yes. So, full PPE is required for both the yellow and the red zone. And that's where we say that face shield, you can keep that face shield on, or you can remove it. When you remove it, you've got to clean it before you use it again. Next question, can we allow a hearing impaired visitor visiting a resident in the yellow zone to wear his or her own mask with a clear window? I saw this question yesterday on the thing, and I agree with Dr. Epson's assessment. If the visitor is one that's hearing impaired, and the resident is wearing a clear mask so that they can read their lips, I understand that. Or if the resident is hard to hear, but I'm not certain why the person hard of hearing would need a clear window mask. But I'm less concerned about it than Dr. Epson is. But I personally, I think that I think the two are the equivalent. If you're wearing a face mask for source control or a face mask with a clear window, neither one of them is respiratory protection. They're both source control of, varying effectiveness. And so, I would say it's okay, but I'm not the one to make that judgment. So I just think that I only posed the question to my health department to ask if that was okay, if it was necessary for the resident to visit and to understand their visitor. If it is, I think it's a clear need to have it, and the risk of a face mask with a clear window versus a face mask for source control is probably minimal. So, you know, if you need it to accommodate the visit, I think that's probably okay. It says we currently do not have any medical or N95 masks with clear windows to accommodate the need. Yeah, and I'm not certain that any N95s are made with a clear window. As a matter of fact, if you wanted a clear window, you would either have to go to elastomeric respirator, which is that crazy Ant-Man looking thing, or you would have to wear the full hood like a PAPR. And neither one is we're going to give to a visitor. So I think in your case, you know, I think it's probably okay. The risk is negligibly different. I would just want to clear it with my health department to make sure that they were okay with that, or the district office for CDPH. For hard of hearing patients, and here's a suggestion from somebody else, for hard of hearing patients, use voice to text translation on a smartphone. And they said, check out the AVA app. AVA in the App Store, and I don't represent AVA, and I have no relationship with them. That's just a suggestion from somebody in the chat box. And patients can read the text while they use the while the user speaks behind the mask. Perfect. Okay. Well, I think we've expired all the questions here, guys. I don't want to draw the folks away from getting logged into the Los Angeles webinar. So hopefully you have a wonderful weekend. Take care. Next week, we'll have the folks from Clark to talk about industrial hygiene, health and safety, mechanical ventilation and energy consumption, and how to do your own hygiene audit. So good stuff coming up next week. Please don't hesitate to join us. If you have questions, as always, you know, my email address is jbelden@caf.org, or you can do info@caf.org. And I know folks don't like to go back and revisit these webinars after they're already done. But if you have had a staff fatality during this response, and you've not already been contacted by OSHA, my recommendation is to go back and watch the video between the two attorneys that we had talk about Cal OSHA and how to prepare for an OSHA audit. We've got a number of calls from people that have had staff pass away with OSHA now coming out to do audits of the records. So I highly recommend that you be familiar with those kind of guides or what it's going to look like if they come to your building. And that is recorded and on the YouTube section of the website. So you can always go do that. If you don't know which one it is, send me an email. I'll find the exact one and I'll send you the link to that. So as always, I hope you guys have a wonderful weekend. Thank you for everything that you do. Take care. See you later. Bye-bye.